Meeting room. We are so glad to see so many people joining us. Just a quick heads up that we will be recording this for folks who registered and weren't able to make it, and we will share it with the community going forward. So if you don't want your face, your likeness to be on camera, please feel free to turn off your camera. If you're okay with being on camera, we are so happy to see your faces. So with that, we are so happy to have everyone joining us. I am Dr. Jory Fleischer. I want to welcome you to this talk. I am joined by my amazing colleague, Sarah. Sarah, do you want to introduce yourself?
Hi, everyone. My name is Sarah Chen. I'm a social worker at Rush with their Movement Disorders Clinic, and I work closely with Dr. Fleischer on several different projects. Including this, it's so lovely to be here with you tonight.
So tonight's agenda is a pretty busy one, but first I really want to give a huge shout out and massive thank you to the Thrive Alive network and team. For those who aren't familiar, this is an incredible community and academic collaboration between the Rush Department of Preventive and Family Medicine and over 150 churches and clergy and community members all across the Chicagoland area, particularly serving the Black and African American community who have for so long not received nearly the resources that are needed to help cope with Parkinson's and related disorders. So we are so, so thrilled to be here tonight. So very quick housekeeping is we will try to have time for questions at the end. So please feel free to put questions into the chat now or jot them down, throw them into the chat later. I promise we will come to them. Thank you to Sarah on the back end who's letting people in as they're joining. Huge props to everyone for joining us. So with that, we are going to see who is joining us. So you should see a poll pop up real quick. So how familiar are you with Parkinson's disease? Would you say not at all familiar, somewhat familiar, very familiar? Wow, you guys are fast. This is amazing. Everyone is caffeinated today. All right. So we have a few very brave folks who said not at all familiar. Thank you for joining a Parkinson's talk. We have the majority, 68% said somewhat familiar and 24% said very familiar. So thank you, everybody. All right. So with that, I'll close this and go ahead and get started. So as I mentioned, I'm Jory Fleischer. I'm a movement disorders neurologist at Rush University Medical Center in Chicago, Illinois. And we're going to talk today about navigating shaky ground, understanding Parkinson's disease, Lewy body dementia, and caregiving. And here are our objectives. So we're going to talk through the hallmark features of Parkinson's disease. We're going to describe the risk factors for Parkinson's and the effect of racial disparities in diagnosis and treatment. We're going to talk through some symptoms that often go unrecognized but can be managed. We're going to understand the spectrum of Lewy body dementia, including Parkinson's dementia and dementia with Lewy bodies. And if that sounds like a jumble of words that are all saying the same thing, you are absolutely correct. It's very confusing to all of us, but I'll try to help sort it out. And then we'll talk through some unique challenges and opportunities for folks who are care partners to people living with Parkinson's disease and Lewy body dementia. And then I will end with sharing resources for families who are living with these conditions in Chicago and beyond. And then we'll try to have time for questions. So I just wanted to start with, wait a minute, she said she's a movement disorder specialist. What does that even mean? So shameless photo of my daughter when she was being very cute several years ago. So a movement disorders neurologist means that I completed medical school to become a doctor, did 4 years of neurology residency training to become a full-fledged neurologist. But most of neurology residency training is actually in the hospital. So we don't see a whole lot of outpatient conditions like Parkinson's. But then did another 2 years of subspecialty training called a fellowship, which really was focused on, so the movement disorders fellowship is focused on Parkinson's and related conditions. So a large part of our training is to observe and notice subtle changes in a person's movement. So we are really not good at parties because we can't talk about sports, we can't talk about all those other things. But what we do notice are very subtle movements and things. So often, we might look around a waiting room and just by observation have a sense of what might be going on with that person. That does not mean it's ever okay for a physician to glance at you and go, "Hey, do you know you have Parkinson's?" That should never be how a diagnosis is made, even though we've heard all too often that sometimes that's what happens or what it feels like out in the community. But I bring that up to say that one of the ways that we learn a lot of our movement disorders training is by asking permission to videotape our patients' examinations so that we can teach ourselves, we can teach our trainees how to recognize symptoms. So I'm going to start by introducing you to Parkinson's and showing you a few videos of real patients with different signs and symptoms so we can put the things that we'll talk about in context. And you can have not just a picture, but a video to put in your mind when I say something like a resting tremor. I want to be very, very clear that every person featured in this talk has given express permission for their videos to be used in educational presentations. So with that, we'll start with the first video. So let's imagine that this is a lady who comes in. She's 70 years old, and she is coming in with about 1 year of right shoulder pain, right arm stiffness, and a few years of having the shakes. Her husband has noticed that when they're walking together, she's not swinging her arms as much and she kind of lags behind, even though she used to be the fast walker between the two of them. And sometimes he'll notice that her hand is shaking while walking. So if we watch this video,
September, August, July.
often we will ask people to do a task that kind of is cognitively distracting. So she's been asked, can you say the months of the year backwards, starting with December and going back to January?
197.
And then she's counting backwards. So her hands were at rest. They're kind of, the weight is borne on the sides of the chair. And hopefully you can notice that she's got a little bit of shake. So sort of side to side, back and forth, pretty constant tremor. That's pretty predictable. If you watch 10 seconds of that and you close your eyes, you could imagine what the next 10 seconds looks like. So that's a classic example of a resting tremor. Often people have a resting tremor in their hands, but it could be in their legs. It could be in their face or their lips. That's what we mean when we say resting tremor.
September.
Let's go to the next video. So this is another lady, and she was being examined by my colleague, Dr. Paul. And what you'll see here when I play the video is he's checking her tone, which is sort of the involuntary stiffness or looseness of the muscles. And this is something that movement disorder docs will do. We call it the massage that you never really asked for, and it's worth as much as what you paid for it. But he's gonna, the video is not really playing. Let's try that again. Oh no.
And all uphill.
Got it.
All right, well, now is where you get movement disorder charades. So we wiggle a person's arms around, often from their elbows, from their wrists. And what we're trying to feel is there kind of the usual amount of give with the muscles if a person is totally relaxed? Do we feel like they're really resisting the movement? And are they fully relaxed? So if someone is fully relaxed and you feel some extra resistance, that we would call rigidity. And if you feel kind of a clickety clacking around, we call that cogwheel rigidity. And cogwheel rigidity is extra stiffness or tightness of the muscles with feeling the tremor superimposed on top of it. Hopefully the rest of the videos work. Let's see. So here.
All right, with the right hand, big wide tap.
I promise they worked before. So Dr. Paul was asking this lady to open and close her fingers. So hopefully you guys can see my screen. So he's asking her to do this with her fingers. And what we're looking for is, do the movements stay big and fast, or do they get slow and small as a person goes? Now, we joke that this is not something that you need to practice before coming to your movement disorder specialist. This is not like flossing on your way to the dentist. No one cares about this besides us. Like I said, we're not good at parties. Okay, but what we are looking for is to see, do the movements get slow and small as you go? So for example, in real life, this might look like your handwriting starts out big at the beginning of a sentence or a paragraph, but as the person with Parkinson's writes, the movements get smaller, the writing is tinier or cramped or slanted in a direction. It feels very effortful or difficult. Or you might start brushing your teeth on one side, and by the time you get to the other side, it's cramped and tiny, and you're really not getting sort of the whole tooth. So that is called bradykinesia, or slowness of movement. And that's what he was looking for here in these videos that won't play.
All right, with the right hand, big wide tap.
And maybe. Oh no. One of the other things that we check for, and one of the cardinal signs of Parkinson's, is a trouble with balance, or something that we call a loss of postural reflexes, which means if you imagine walking down your sidewalk and someone passes too close and they bump up against your shoulder and are pushing the other direction, do you take a quick step back to catch yourself? Do you take a step or two? Do you take a bunch of little steps? Or do you just fall back over? And so we check people's postural reflexes. We check their balance in the office using this pull test. And I think I saw someone asking in the chat, do all the folks here have Parkinson's? So everyone here has Parkinson's in these few videos. Yes, we are going to talk about Lewy body, I promise. Okay, let's see, maybe our different lady.
Your index finger and your thumb, can you tap as quickly and as wide as you can?
So here again, we're looking to see, does she have big,
She goes wide as
big
you
and
can.
open? But you can see it's almost like someone is pulling a resistance
very
band.
good. Now the same
around
thing
her
with your left
fingers,
hand.
and they're kind of getting smaller as they go. And with this lady, you can see that there's actually an asymmetry. If you notice, her left hand is even smaller. It doesn't start out quite as big when she taps, and it gets tinier really quickly. The other thing that you might notice is she looks kind of sad, or maybe she looks depressed, right? She's not really showing a lot of facial expression. But what we're actually picking up on is what we call hypomimia, or masked face, or sort of decreased facial expression or emotion on the face. It does not mean that the person isn't feeling emotional. It does not mean that the person has dementia and is checked out. But there's a lot of stigma that often goes when we see someone who has that kind of flattened lack of emotional expression. And that also is a sign of Parkinson's.
Your index finger and your
And here we have this same lady, and we're looking at her walking, or her gait. So the things to notice as she's walking before I play the video are, we want to look at things like posture, and even just here, is she standing up out of the chair? Is she standing up straight? Is her head up straight? It's actually not. She's kind of stooped over at her shoulders, and she's stooped over at her neck, kind of looking downwards. So we notice things like that. We notice shoulders, we notice posture. We notice if a shoulder is elevated one side or the other. Often we can see this in Parkinsonism. We look at the position of someone's feet when they're at rest. Are they standing? Do they have a good base of support? So here her feet are kind of far enough apart that she looks balanced. But sometimes people stand with their feet really close together, which impairs their balance. And so as she's walking, we look at, does one step to the next? Does it look big? Is someone taking good steps one to the other? Are they changing from one step to the other? Are they getting smaller? Really kind of subtle things, but this is what we look at when we're making a diagnosis of
Are
Parkinson's.
you comfortable doing that without the walker?
Yeah, I try to do it on my own.
Okay.
We also look at arm swing. So you can see her right arm is held kind of bent close to the body. The left arm is also not moving, but it's kind of extended out a little bit more. And even though when she stood up, her feet were pretty wide apart, she's quite narrow here. And this tiny little turn, she's trying to turn around. We would hope someone would just kind of pivot as they turn. But she takes a lot of little tiny steps to turn around in place. So we call this a turn and block. And it's a little bit easier to see as she's heading backwards. You can see her kind of bent forward from the waist, bent forward from the shoulders, and her head is
Okay,
facing
and then
down.
one more time, this blue line and back to the chair.
Thing. She's going to stop right here, and you can see her posture even more. So even as we age, while we can have a little bit of change in posture, this amount of being bent forward at the hips and bent forward at the shoulders, this is outside of what we would expect for normal aging. So let's talk through when someone sees a movement disorder specialist. If someone is sent in with they have shakes or they have a tremor, there's some question of what's going on. What we look at first is, does the person have Parkinsonism? So Parkinsonism is a description of a group of symptoms. It's kind of like saying someone has a headache. It doesn't tell you what kind of headache yet. That you have to narrow down with some other things. But to say someone has Parkinsonism, we look for that bradykinesia, the slowness of movement with the finger taps, with hand opening and closing, with flip-flopping of the hands and tapping of the feet. We look to see if their facial expression looks decreased. And then we're feeling for that stiffness of the muscles with rigidity. We're looking for a tremor, and we're looking at their balance and their posture changes. Are they stooped over? Are they swinging their arms when they're walking? Are they shuffling their feet? What's going on as they're taking those steps? And if someone has that bradykinesia, the slowness of movement, and either of these three, you only need one of those other three, then we say, yes, they have Parkinsonism. And if you have Parkinsonism, then you're kind of in this box. And the most common cause of someone having Parkinsonism is Parkinson's disease. However, there are some other things that also are included in this box. We'll talk largely about dementia with Lewy bodies today, but happy to provide resources on some of the others. So let's get into how do we go from Parkinsonism to Parkinson's disease. So unfortunately, I just had this conversation today with a close friend. They said, Jory, isn't there a black and white answer to does my loved one have Parkinson's? And I said, as of today, July 21st, 2025, we still do not have a black and white 100% test while a person is alive to say that they have Parkinson's disease. We can get pretty close. And so the clinical examination, seeing a neurologist, seeing a movement disorder specialist particularly, remains our gold standard of making a diagnosis of Parkinson's disease. So a general neurologist who's done that 4 years of neurology residency, they're about 70%. And a movement disorder specialist who spent another 2 years just thinking about Parkinson's all the time is about 90% accurate compared to looking at a person's brain under the microscope after they've passed, which is the only way that we ever know 100%. But the things that help us in life to make that diagnosis are those motor features that we talked about. Where'd that go? So the slowness of movement, the rigidity, tremor, balance, and posture changes. And things that push us more towards this being Parkinson's disease are if symptoms started on one side, so unilateral onset, and even as time goes on and things may spread to another side, the side where everything started is always the side that's going to be most affected. We will try levodopa. So levodopa is actually dopamine. It's what the person's brain is missing that's causing their movement symptoms of Parkinson's. And so if we basically supplement them, if we give them back the missing dopamine and they respond, some of the movement gets better, we say, okay, we're on the right track. If someone develops extra movements, if you picture Michael J. Fox, who's got some extra fidgety wiggly movements, that's actually a sign that his brain has responded really well to getting levodopa back. And as Parkinson's has progressed over years and years and years, has become kind of hypersensitive and kind of increasingly dependent on that extra dopamine and develops kind of extra movements. Other things that point us in the direction of Parkinson's are in the years before, has the person had a gradual change in their sense of smell? So gradual decrease in sense of smell or olfactory loss. This was a Parkinson's thing before it was a COVID thing, okay? So if you lose your sense of smell overnight, you should be checked for COVID. If you've gradually lost your sense of smell over the last 10, 15, 20 years, this is something that can happen, can be seen in people with Parkinson's. Similarly, something else that goes on often for years or decades before is what's called REM behavior disorder, which is where people are having vivid dreams. They're in sort of normal times of sleep, but they're acting out their dreams during sleep. So there's a switch in the brain that should turn off so that if I'm dreaming about cooking, no one knows it. But if I have REM behavior disorder and I'm dreaming about cooking, you might see me stirring something or moving pot lids or doing things in my sleep and not realizing it. So that can happen years or decades before someone has the first slowness or stiffness or tremor. And finally, constipation. People can be constipated for all kinds of reasons. Just because you're constipated doesn't mean necessarily that you're on the way to Parkinson's. However, it's very, very common when we look back in folks that they've had gradual changes in their bowel habits, often for decades, and that can be a precursor symptom of Parkinson's. One thing I want to note is that often people hear Parkinson's, they picture Parkinson's, and they think tremor. But about 30% of people with Parkinson's never develop a tremor. So doesn't always mean that it's going to happen. So what is actually going on in the brain with Parkinson's? There is an abnormal accumulation of a protein called alpha-synuclein. So this protein is supposed to be there. It has a bunch of jobs in the normal cell, but for reasons that we don't fully understand, something causes the normal alpha-synuclein. If we picture it like a little squiggly line, it causes that normal squiggly line protein to crimp. And when that protein is crimped, it stops doing its normal job. And it also can bump into other normal alpha-synuclein in the cell, bump up against it, cause them to crimp. And when two crimped alpha-synuclein bump into each other, they stick together. So they glom up. And then this basically happens like a domino effect in the cell. All of the normal alpha-synuclein gets changed into glommed up sticky alpha-synuclein. And the brain cell says this is not supposed to be there. This is glomming up the works. And it basically cordons it off into a garbage bag. And that garbage bag, if we look here on this slide, is called a Lewy body. It's this light pink circular blob in the middle. So that's basically the cell trying to heal itself. It said like, you're not supposed to be here, get away. But eventually, the cells that are most affected, when there are too many Lewy bodies inside that cell and it can't function, that cell dies. And unfortunately, it doesn't go quietly off into the night. It basically kind of spills. Imagine that the garbage bag burst open and it spills out into the space between cells, which means that that glommed up alpha-synuclein can go to the neighboring cell, which was just fine and minding its own business, and go up to the normal straight alpha-synuclein, crimp it, and start the whole process over again. So that's how we think Parkinson's can spread from cell to cell. And the area of the brain where we see this cell loss most often, and especially early, is in what's called the substantia nigra. So this is a cut through someone's brain stem. This is someone who did not have Parkinson's, and we can see this kind of dark stuff. That dark stuff actually has a fancy name, and the fancy name is substantia nigra, which means dark stuff. And in someone with Parkinson's, it's those cells that are dark. These are those cells at high view under the microscope. Over here, this is in the brain of someone with Parkinson's. We don't see nearly as many of those dark cells. And when we look at the big picture, we don't see nearly as much of the dark stuff over here in Parkinson's. So unfortunately, those cells are producing dopamine, and dopamine is a natural chemical in the brain that helps you move. It also helps with regulating mood and a bunch of other things, including motivation. And by the time someone first has a tremor, slowness, stiffness, they've actually lost about 50 to 60% of the dopamine that they were producing before Parkinson's started, which means we're kind of only aware of symptoms when we're already kind of halfway through the process in the brain, at least. So this is why there are a ton of people, many, many, many researchers working to figure out what are the earliest signs before anyone has any symptoms, so we can pick people up long before there's a problem and treat them and get them on the right medications and prevent any symptoms in the first place. So as I mentioned, dopamine is kind of this key chemical in Parkinson's, and we think about it as a movement disorder, but that's not the whole story, because dopamine plays a vital role in movement, in cognition or memory and thinking, in reward or motivation, and in pleasure. If you take a bite of a great chocolate cake and you're like, oh yes, I would like more of that, please, That's dopamine firing in your brain. If you go to the casino and you win, and you're like, yes, I would like to do that again, I will cha-ching. That's dopamine telling you to do that more. So dopamine plays a big role across the brain. And dopamine isn't the only story in Parkinson's because serotonin, which regulates mood, and norepinephrine, which regulates kind of alertness and anxiety, are also affected. So we're talking about being affected by Parkinson's. Who is affected by Parkinson's? So this was actually first described by a doctor, James Parkinson, that's who it's named after, back in 1817. And he wrote this essay on the shaking palsy. And he described in it seeing 3 people in his office and 3 other people walking the streets of London who he never met. And based on his observations alone, he described much of what we know about Parkinson's, which is why they named it after him. This is the second most common neurodegenerative disease in the world. So it's second only to Alzheimer's. And age is the #1 risk factor. So as we age, the risk of Parkinson's goes up. And many people are surprised to learn that at the age of 60 and above, the risk of any given person in the population is about 1 to 2%. So if you have a room of 60-year-olds and you've got 100 people in that room, 1 or 2 of those folks will go on to develop Parkinson's, which is higher than most people usually imagine. And if we take people 80 and over, it's about 3 to 5 out of 100. So right now in the United States, there are at least 1.2 million people living with Parkinson's, and that's over 10 million around the world. It is slightly more common in men than women, but it's also very underdiagnosed and underrecognized in women. And one of the questions we get asked all the time is sort of, why did this happen, right? Is there something that I did to make this happen? There is nothing that anyone did to give themselves Parkinson's. I want to be very, very clear about that. There's increasing research about what are some of the risk factors, though, and trying to do a lot of advocacy to try to prevent some of those things. So some examples are certain pesticides. So we've known for quite a while that people who live in rural areas and are drinking well water and farmers are at a higher risk of Parkinson's. We know that folks who are exposed to certain solvents, which are like degreasing chemicals and older dry cleaning agents, are at a higher risk of Parkinson's, and folks with repeated head trauma have an increased risk. There are also geographic areas of the US, so places like the Rust Belt. So I'm coming to you from Chicago, well inside the Rust Belt, but the Northwestern and Midwestern US with lots of industrial manufacturing, areas in Southern California, Southeastern Texas, Central Pennsylvania, and Florida also seem to have higher risks of Parkinson's. And racial disparities are a huge issue in Parkinson's, as they are in so many areas of health. So I want to be very, very clear that Parkinson's has long been under-recognized and underdiagnosed in individuals of color, with many possible factors contributing to this. So there have been papers studying differences in expectations around normal aging. There are also differences in healthcare seeking behavior. And sometimes that may be because of well-founded concerns about receiving healthcare and receiving equal treatment from healthcare professionals. Many individuals may have decreased access to specialty care. So if someone is in a rural area, they have less access to even a general neurologist, let alone movement disorders specialists. And if someone is right smack dab, they could be right next to Rush, but they have no insurance. It may be very difficult for them to get seen by a specialist. We also know that non-white populations were recruited at disproportionate rates for military service during the Vietnam War, and there were unique exposures during the war to things like traumatic brain injury and Agent Orange that are associated with a higher risk of Parkinson's disease. And finally, I will tell you that in almost every single textbook of Parkinson's, every article about Parkinson's that I see as an academic movement disorders neurologist, there is a common image that is shown to healthcare providers and trainees, and that is an older white man bent over with his hand drawn so that it looks like it's shaking. And if we are constantly taught that the picture of Parkinson's is an old white man, then all of the implicit bias when there is a younger Black woman in front of us makes us question, could this be Parkinson's? Probably not. It must be something else, even if that's entirely subconscious. So I want to be really, really clear that this has led to differences in diagnosis. There are treatment disparities faced by individuals of color. So we know that Black individuals are far less likely to receive a diagnosis of Parkinson's, to receive treatment even after they've gotten a diagnosis, to be referred to physical and occupational therapy, which we know makes a difference, to be recommended for deep brain stimulation, which is an advanced intervention that is appropriate for some people with Parkinson's, but not all. And there are lower chances of being referred to see a neurologist if a person is an individual of color, and even more so if they are a woman of color. So we have huge hurdles to overcome in our field. They are finally being recognized and acknowledged, but I will tell you, we have a ways to go. So we also know that within the realm of Parkinson's research, and there are thousands, if not tens of thousands of labs all over the world trying to solve everything from where and how does this first start to what is the best thing that we can do from a medication perspective, a vitamin, a diet perspective, an exercise perspective. There are so many research studies going on. And there are a lot of racial disparities in Parkinson's research. In many, many studies, the ratio is about 96, 97, 98% white individuals with Parkinson's disease. So for us to have better ideas about how to serve the whole population, we need to create research studies that are more welcoming and that meet people where they are. And there are a lot of people working to do that. So I also want to touch on another area of disparity in Parkinson's, which is folks with more advanced Parkinson's. So the good news is that with aging of the population and increased life expectancy and better clinical management, Parkinson's today is a different disease than Parkinson's was 10 years ago or 50 years ago, which is wonderful. All of this means that we have more people with Parkinson's living longer and living longer with Parkinson's and more advanced Parkinson's than we've ever had before in the history of the world. However, people often ask, well, what are the stages? What stage am I at? So here's the staging system that we have. And I will tell you, it is flawed. Okay. So it's the Hoehn-Yahr scale. And this really just takes into account movement symptoms. So if you have symptoms just on one side of the body, whether you feel symptoms on one side of the body or not, if I'm looking at you and I think, well, I only notice symptoms on one side of the body, that's a stage 1. If, however, even if you are only noticing stuff on one side of the body, but when I examine you, I see a little bit of tremor sneak out on the other side, or there's some slowness or some stiffness on the other side, as soon as there's involvement of both sides of the body, that's stage 2. As soon as there's involvement of balance or posture, that's someone who's at stage 3. And if someone is more impaired by their Parkinson's movement symptoms, they're slower, they're stiffer, they're having a harder time walking, but they can walk with a walker or a cane, that's stage 4. And stage 5 is someone who requires a wheelchair or is bedbound unless they're fully assisted by another person. However, if we look at this diagram with the blue triangles, we talked about, and you saw videos about the bradykinesia, the slowness of movement, the rigidity, and the tremor. These are the cardinal or hallmark features of Parkinson's disease. What's all this other stuff? This is all of, not even all of, but many of the other symptoms of Parkinson's. And what this is showing is that as time goes on, all kinds of other symptoms creep in. And actually, the slowness, the stiffness, the tremor, these are kind of smaller issues in comparison to falls, trouble swallowing or dysphagia, dementia, orthostatic hypotension or dropping blood pressure, urinary symptoms, constipation gets worse over time. There are all kinds of things. And yet we have the staging system and it doesn't even talk about any of that. The other problem with the staging system is if we think about, all right, well, where am I on this staging system and what counts as advanced? If you look at tables of advanced Parkinson's, they're often referring to stage 3. So if we're calling stage 3 out of 5 advanced, what are we calling stages 4 and 5? And for way too long, we haven't been calling them anything because we've kind of forgotten that they exist. But I will tell you that this is who we see in my clinic. This is who my research program is dedicated to. People do not just fall off of a Parkinson's cliff. People are living and thriving with Parkinson's in stage 4 and stage 5, and there are things we can do at every step along the way. So with that, symptoms that we can do something about, okay? This is not going to be a super detailed dive into all the medications, but what I do want to show you, this is, I think, the most sciencey slide that I have, is this is supposed to be a drawing of the end of one of those dopamine-producing brain cells. It kind of reaches out its little extension there, and it's spitting dopamine, that chemical that helps us move or that gives us motivation. It's spitting that out. These are the little dopamine triangles into the neighborhood, into the synapse between itself and the neighboring cell that needs to see the dopamine. So if you're making less because these cells are dying off before they should, well, we can just give you back more dopamine. So that's called levodopa. Or we can sort of prevent stuff from being recycled, prevent it from kind of flittering away. We can give other things that kind of mimic dopamine, but don't quite do the same thing. So there are a lot of different ways that we can kind of get into the way that cells are talking with each other and help and improve symptoms. That said, here's the general idea behind treating movement symptoms. So by the time someone notices symptoms, I've mentioned that they've already lost 50 to 60% of their dopamine producing cells. So imagine that this red line is their dopamine level, and it's just kind of going down over time. This is not drawn to any kind of scale, okay? But symptoms become noticeable at a certain point where this green arrow is. And then at some point, and that point should be individualized, but it's when the person with Parkinson's says, my symptoms are getting in the way of me doing, insert whatever here, hanging out with my kids, my grandkids, doing my job, doing my exercise routine. If it is getting in the way of life, that is the trigger for that person to start treatment, okay? And what we do with treatment is we say, we can't, unfortunately, take the Parkinson's away. We don't in 2025 have a cure, but what we can try to do is give you back some of the dopamine that you're missing, or mimic the dopamine that you're missing, to try to get you functioning as if you're back up at this baseline, at the dotted line at the top. We'll never quite get to 100%, but we'll say that if you're making, say this red line is down to, you're making 50% of your own dopamine, and we give you what we estimate to be 50% back. Hopefully, that has you functioning at about 100%. The challenge is, as time goes on, a person with Parkinson's is making less and less of their own dopamine. So if we start the medication here and we say, all right, they're making 50%, we're giving you back 50%. 50% is the medicine amount. And time goes on, time goes on, time goes on. They come back a year later, 2 years later, and they look at me and they go, Doc, your meds aren't working anymore. They used to do the following, but now they're not. The downside is it's not actually the meds, because the meds are doing what they used to do. They're living their best life. They're doing everything in your bloodstream and in your brain that they used to do. The issue is that what you are making is less. So if 50 plus 50 added up to 100 before, now you're making 30. And if we keep that medicine the same dose as 50, it doesn't add up to 100 anymore. So over time, we need to adjust the dose of the medicine. The myth is that it's because the medicine stops working. The medicine doesn't stop working. We just need to keep pace with the Parkinson's. So here is the other analogy that I really like for thinking about treatment with Parkinson's, is that if anyone has little kids, has grandkids around, or maybe you just have it in your medicine closet, folks have that multi-pack of Band-Aids, right? And on the right side here, this is like the little dinky pinky size Band-Aid, okay? This is kind of our approach to medications for the movement symptoms in Parkinson's, is when things are really mild, symptoms are starting to be bothersome, but they're not terrible, we can reach into our medicine toolkit and we can pull out the pinky Band-Aid equivalent. Okay, so if you imagine that you've got a birthmark and you just want to cover up that birthmark, the dermatologist says it's okay, it's not cancerous, but you just don't like seeing it. You could put the tiny pinky-sized Band-Aid over that birthmark, and for months, years, it might be fine. You'd see the Band-Aid, but you wouldn't see the birthmark underneath. But one day, you will look down, and that birthmark has been slowly growing over time and it's going to peek out from beneath the pinky-sized Band-Aid. It's not that the Band-Aid stopped working, right? But your choice at that point is to say, okay, well, I got another pinky-sized Band-Aid. Let's add on another one, another low dose, kind of lower potency medicine next to it. Or you can take off the pinky-sized Band-Aid and you can go to a bigger Band-Aid, a higher potency medication to treat the Parkinson's. And if I haven't tortured that analogy enough, here's another analogy to think about how we treat people with Parkinson's in terms of the movement symptoms, which is that in most medical conditions, there is a trade-off between medicines that are really, really safe, very low side effect profile, and medicines that are really, really powerful, really going to fix the symptoms, right? But for example, if we take someone who's got bad arthritis in their knees, we could say, just try rubbing some icy hot or some Bengay on it and, doing some stretching exercises. Chance that it's going to make a huge difference? Probably not super high. Chance that it's going to cause a ton of side effects? Also not very high, right? Or we could just send them straight to our orthopedic colleagues and say, it's time for a knee replacement. That's a pretty big gun to reach for, right? And it's got a huge chance of helping, but also a pretty big side effect profile. If you have someone with diabetes, for example, we could start and say, let's start with diet and exercise. Pretty low risk of side effects, but also kind of hard to stick to and maybe really hard to see a big change. Or we could prescribe them an insulin pump and we could see a big change, but it's not without some pretty significant side effects, right? So most areas of medicine, our options are kind of trading that off, the safe and the wonderful. But in Parkinson's, because we have levodopa, which once it gets to the brain is dopamine, it's what a person is missing. Our safest and our most powerful is actually one and the same, which is pretty unique. So that's about all that I'm going to say in terms of Parkinson's medications, because it's also really important to realize that especially for mobility, meds are just one piece of the puzzle. So physical therapy is huge. It should be part of everyone's prescription if they're living with Parkinson's. It can help with freezing of gait, which is, if you remember that lady who was wearing kind of dark green and she had those tiny little steps, especially when she turned, that's freezing of gait, when your feet kind of get stuck and you can't take a step. Someone who's a physical therapist who's been trained in Parkinson's is going to be head and shoulders above someone who's never really been trained in Parkinson's. So if you're referred for physical therapy, this is a website, and will share out the slides with anyone who wants them. But this is a great organization that trains physical therapists and occupational therapists and speech therapists to know about Parkinson's and do the stuff that's been shown to help. Occupational therapists are sort of our troubleshooters. They are amazing at figuring out, I can't type as well as I could anymore. How do I get around this? Or I'm having trouble doing XYZ, activity of daily living. Or I'm falling in the home and coming to the home and being able to do home safety assessments and recommend adaptations that can help keep a person safer and in their home for as long as possible. People with Parkinson's have what's called hypophonia, where they might start talking loudly, but as they get to the end of the sentence, they taper off and they're really, really quiet. So there's speech and language therapy that has been shown to be helpful. You have to do it, and it has to be the right speech and language therapy by someone who knows Parkinson's. So that's called LSVT Loud, and they are all over the US. Also, as time goes on, especially if someone develops changes in their memory or thinking, they may have a hard time remembering all the things that they're supposed to do or that their therapist told them. So it's really important to have care partners who can help cueing and reminding and nudging to remember those things that need to happen. All right, additional symptoms of Parkinson's that I want to make sure we touch on. So depression. This is not just a reaction to getting a diagnosis. Everyone is allowed to be sad and feel depressed anytime they have a life-changing diagnosis, whether it's Parkinson's or knee arthritis that requires a knee replacement or diabetes or anything. But Parkinson's, on top of that, changes the chemistry in the brain, not only of dopamine, but of serotonin, which regulates mood. And so when we look with research at all of the different symptoms of Parkinson's that contribute to quality of life, depression is actually number one. We could give you the best tremor medication in the world, but if someone is depressed, number one, they're not going to take the medicine. They're not going to get up. They're not going to do their exercise. They're not going to do their therapy. we're wasting all of that unless we treat the person's mood. And again, this is not something that they can just kind of snap their fingers and snap themselves out of. This is as real and as physical a symptom as everything else. So while we know that involvement in social activities and support groups and exercise, and especially psychotherapy, can be very beneficial, the kind of is that if someone has been in therapy and they're getting along with their therapist, they're meeting with them weekly, and they've had at least 12 weeks of therapy and their mood is still in the dumps, that's a time when medication should be considered to help them, because that will help all of their Parkinson's. And similar to depression, anxiety is incredibly common in Parkinson's. This could be a general anxiety. Someone who wasn't really nervous before is now kind of on edge all the time. It could be very specific that the appointment is in 3 hours. It's going to take us 45 minutes to get there. We should leave 2.5 hours early, just in case. There's a lot of driving and parking anxiety. There's a lot of social anxiety, people noticing the tremor and what will they think and what am I going to do? And so this, just like depression, just like tremor, is caused by chemical changes in the brain that we can do things about as long as we acknowledge them and we work on them together. And one really sticky symptom is apathy. So apathy is a loss of motivation. And this is something that usually a person with Parkinson's is not going to report. Their loved one, their care partner, the family will sit there and go, I think he's depressed. And the person will go, do you feel depressed? No. Do you feel sad, blue, hopeless, guilty, worthless, all the things? No. It's just kind of And that meh, right, is someone often where they don't feel like going to things that they enjoy, but if they're brought to the thing that they enjoy, or the stuff that they enjoy is brought to them, they do still enjoy it, right? And so it's just that loss of motivation. And this is a very common symptom in Parkinson's and related disorders. And we really want to treat it. We don't have a perfect medicine for this, but having a schedule can really, really help the person, making sure that the care partner and the family understand that this isn't willful. This isn't the person choosing to ignore all of their care partner's hard work, setting up their schedule and getting them all the things all lined up. This is actually the disease too. All right. We're going to talk a little bit about autonomic symptoms. So I joke that I went into neurology and I had no idea how much of my day I would spend talking about poop. I'm also a mom to small children. So there we go. I come home and it's there too. But Parkinson's really affects the gut and it causes a lot of constipation. So people usually may think like, no, I'm not really constipated. I've been like this for a while. And what we mean by constipated is if you are straining to have a bowel movement regularly, if you are going 2 or 3 days or 4 days or longer between bowel movements, and that's not what your pattern was when you were in your 20s or 30s, that's constipation. And Parkinson's affects the gut and may affect the gut actually before it even starts in the brain. So usually we need an acute treatment plan. We need to get people unstuck when we recognize it. And then we need a prevention plan that will keep them from getting restuck. So hydration, fiber, usually in their diet, better to get fiber from an apple, fiber from fruits and veggies instead of a powder. And exercise will help prevent it. And there are other things that we can do. Our number one safest and most effective, kind of similar to levodopa, but our levodopa equivalent in the constipation world is what's called polyethylene glycol. The brand name of this is Miralax, but the generic is absolutely the same. Costco has it, Sam's Club has it. The polyethylene glycol is not actually absorbed by your body. It stays in the gut and it's kind of like flushing a toilet. It brings water into the gut, helps pull everything out. Usually people are pretty stopped up to begin with, so there may be a couple of days of unpleasantness as we get everyone cleared out and kind of go back to a normal baseline. And something that can go with this is what's called orthostatic hypotension. So we think about the nervous system as kind of the brain and the spinal cord, but there's actually a huge number of nerve cells in your gut and throughout your body that control things that we take for granted, or the automatic stuff like bowel and bladder function, like temperature regulation, and like blood pressure and heart rate control. So people with Parkinson's and related disorders can have orthostatic hypotension, which means when they change positions, going from seated to standing, They may feel really dizzy, really lightheaded, and that's because the blood has pooled in their legs and their gut and hasn't fully made it back up. So there are a lot of things that we can do about this. For the sake of time, I'm not going to go through them all, but if this is something that's going on in you or a loved one, please know that it is a big reason for people to fall and we can treat it. So please, please, please mention this to your healthcare provider if this is happening. Also, drooling. This is part of that autonomic system. The drooling is because people aren't swallowing as frequently, and we also have a lot of treatments that can help this. We're going to get into a slightly scarier topic about memory and thinking. And someone had asked in the chat earlier, are you just talking about Parkinson's or I joined because of Lewy body dementia? We are glad that you are here. So here we go. So Lewy body dementia is a super confusing term, okay? I did not come up with this term. We all can agree that it's terrible terminology, all right? But bear with me for another stupid analogy. I like to think about this as a chicken and an egg problem under an umbrella. So here's what I mean. We have talked about Parkinsonism, bradykinesia, slowness of movement, stiffness, tremor, balance changes. Parkinsonism is our chicken, okay? And then we're going to talk about a specific kind of dementia. So just like the term headache, people hear dementia and they really picture one thing, which is Alzheimer's. So someone who asks the same questions over and over and over, doesn't remember the thing that happened yesterday, eventually may not recognize their family and friends. That is the most common form of dementia. It's the most common neurodegenerative disease. And that is not this. I'm going to say that again for those in the back. That is not this. The dementia that we see in Parkinson's and in Lewy body dementia is primarily changes in attention, concentration, decision-making, visuospatial processing, kind of recognizing where you are in the world and where things are around you in the world. People have these fluctuations in alertness, which means that the person could be having a conversation, they're totally sharp, they're spot on, they're talking about politics or whatever is going on really, really well. And 5 minutes later, it's almost like family can kind of describe seeing them become glazed, dazed, confused. They're not unconscious, they're conscious. They might still be talking, but it might be a little bit less logical, harder to follow. It's harder for them to get the words out. There's nothing that the person or the family can do to snap them out of it. It's just kind of waiting for it to pass. So I almost envision if you're taking off in an airplane, you know that you're going to go through a cloud layer, and only the pilot really knows when you're going to clear it, right? And so you're not in control of that as a passenger, neither is the person across the aisle from you. And so it's kind of waiting for these fluctuations to pass, but those fluctuations are really common. And hallucinations. Someone is seeing something that isn't really there. We're going to call this group of symptoms, this type of dementia, our egg, okay? So for many people, they develop the Parkinsonism first, and they're diagnosed with Parkinson's disease. And at least a year later, but for most people, 10, 15, 20 years later, they develop those dementia symptoms. In that case, we say the person has Parkinson's disease dementia, or PDD. However, there are people who did not read that textbook, and they develop the dementia symptoms first. And then at some point down the line, they develop some of the movement symptoms. Or there are people who develop the cognitive, the dementia symptoms, and the movement symptoms within a year of each other. And we say that that person has dementia with Lewy bodies. Confusing enough? Here we go. Whether you have Parkinson's disease dementia or dementia with Lewy bodies, if you've got both the chicken and the egg, regardless of who arrived first or whether they came in the basket together, if they are both there under the umbrella, we call that Lewy body dementia. So if someone with Parkinson's goes on years later and is told they have Lewy body dementia, it's not a different diagnosis. It's really part of the same thing. If someone has dementia with Lewy bodies and they're told you have Lewy body dementia, it's part of the same thing. Okay, so what do we do about these cognitive symptoms? Number one is recognizing if you are a family member, if you're a care partner, this is part of it and it's not under the person's control. It is different than Alzheimer's. It's different than that picture of dementia that we often see on TV or, on TikTok. The executive function means a person who used to be okay with managing the finances, doing the checkbook, may get really, really confused by that and make a lot of errors now that they never would have done in the past. The visuospatial function means that someone who had a great sense of direction before is now getting turned around even in familiar places. They go out to go to the Walgreens on the corner and they come back 2 hours later and can't quite tell you what happened. So we want to think about driving safety. Doesn't mean that everyone with Parkinson's, everyone with Lewy body can no longer drive, not at all. But it means that if you're noticing these subtle symptoms, that's a reason to get a driving evaluation, which an occupational therapist can help with. Also, people can develop hallucinations and delusions, so we want to think about safety precautions. If someone is having these cognitive changes, there are a lot of non-medication things that we can do, increasing social interaction, increasing their physical activity, giving them a daily schedule, bringing in different kinds of memory aids to help them. So instead of asking about what's happening today, what's going to be on the calendar, having a shared whiteboard with a calendar that everyone can take a look at. And we do have medications that can help. Interestingly, the medications that we reach for are originally Alzheimer's medications from decades ago. However, in people with Alzheimer's, they're sort of Most of the time, people take them and they don't notice any improvement. But what we think is that more like a vitamin, they're working underneath on a microscopic level to slow down how quickly the person would otherwise be worsening. And to some extent, that's the same in people with Parkinson's and Lewy body. However, there's a significant chunk of people where they start on these medications and family comes back and goes, yeah, they're about the same. I don't notice any difference. And in a disease that's otherwise progressive, about the same is actually a win. It's not the win that we would want, but in some folks, about 20 to 30% of the time, these medicines do actually lead to a clear improvement in word finding, sometimes even in walking for very complex reasons because the brain is more complicated than any of us understand. But we have medications to treat this. We start really slow. The expectation should be that this is slowing the rate of progression, and sometimes this can help with hallucinations. So just to touch briefly on the hallucinations piece, people can often feel someone in a room who's not there, or they can see kind of like you might see someone picking at lint on their clothes or sweeping invisible crumbs off of a table, reaching out to the ground to pick up bugs that only they see. But over time, these can evolve into simple shapes kind of floating through the air, to seeing little animals like birds or mice in the room, to seeing people or groups of people. And if they continue unchecked, they can become really frightening. People usually have insight. They recognize it's not real when it's happening, but as time goes on, they may lose that insight. And often this can become scary and this can be a source of aggression. So in about 65% of people with Parkinson's, their care partners report that there's been some form of physical aggression towards them. And in more than a quarter that there's been sexual aggression. And we often think that this is because of hallucinations or delusions that are untreated. But we have things we can do to help with this. I won't spend a ton of time on delusions, but only to say that there are certain things that are really common in Parkinson's and Lewy body, including paranoia, which can be generalized, just people being more suspicious of everyone, more suspicious of certain things. The government is tapping them through their phone lines or their computers, people stealing money from them. But two really important types of delusions that are pretty unique in Parkinson's and Lewy body. One is delusional jealousy or Othello syndrome. And this is where the person with Parkinson's or Lewy body is absolutely convinced without a shred of evidence that their significant other is cheating on them. And they might not be able to say that, but it might manifest as every time the care partner picks up the phone because the plumber's calling or someone else is on the phone, the person with Parkinson's or Lewy body, gets really suspicious, gets really agitated. Who is that? Who are you talking to? Why are you talking to them? And no matter how many times you say, it's just the plumber, the toilet's clogged because you're not taking your Miralax, right? They can't sort of get over that delusion. The other is Capgras syndrome, which is the belief that someone or something or some place has been replaced by an imposter or a lookalike. So instead of, you might walk in the room and they say, when is the real Judy coming home? When is the real Mike going to be here? And you're like, I'm I'm Judy. I'm Mike. What are you talking about? That is actually a common symptom that we see in Lewy body dementia. And these symptoms taken together, the hallucinations, the delusions, we group these and call this psychosis. And that, independent of everything else, predicts the risk of hospitalization, institutional placement, and caregiver strain. I'm going to skip over sleep for the sake of time, but Parkinson's and Lewy body mess up sleep in every way possible. And there are ways that we can treat almost all of those ways. So if your loved one is having trouble sleeping, please talk with their doc. I'm not going to go through this very, very busy table, but this comes from an article where my team and I actually spent years in New York and then in Chicago doing home visits. I told you that folks in that hone and yar stage 4 and 5, they don't show up in research studies. It's because they don't show up in clinic a lot of the time. When it becomes really hard to get to clinic, you don't see the Parkinson's neurologist. And the Parkinson's neurologist might think, well, that's okay. I'm sure they're seeing their primary care doc. Often folks are at home and they're dealing with all of those symptoms. If you remember back to that diagram with all the blue triangles, there are all kinds of symptoms. But this table and the next one are just here to show you that for all those symptoms, the ones that I've talked about and lots more, we have things that we can do that have been proven to help, both non-medication things and medication things, especially when we combine them together. We can make a huge amount of difference. People just need to recognize and be able to get to care. All right, one more myth to bust, and that is that I have Parkinson's and I will wake up one morning and. So Parkinson's is a slowly progressive, and Lewy body is a slowly progressive condition. There is no wake up one morning and, okay? Those dopamine neurons in that substantia nigra, the black dark stuff, they're not unionized. They don't go on strike altogether, okay? They're dying off slowly over time. However, it often feels like Friday at 4:30, we get the call that all of a sudden, my loved one or I have had a sudden change in mobility. I'm falling a bunch. The meds aren't working. Something else is going on. Or sudden confusion. Or new hallucinations or delusions that a person's never had. Or they're suddenly worse. What is going on? The answer is it is almost always a urinary tract infection. Okay? Almost always. And the emergency room won't think about it. Okay. But I'm telling you, if you're hearing this, always, always, always think about the urine. Okay. So it is the most common cause of someone to have a sudden change in their movement disorders, their neurologic symptoms. It's because your brain is actually compensating all the rest of the time and helping you function a little bit better than you otherwise would. And if something else goes on, there's a urinary tract infection, there's a pneumonia, there's COVID, there's the flu, there's something else, that extra compensation goes away. And we kind of drop down and you wake up one morning and. But that is not the Parkinson's, that is not the Lewy body, that is something else going on in the body. If it's not a urinary tract infection, it's pneumonia. If it's not that, it's a sneaky source, like a dental abscess, a foot ulcer, especially if someone's diabetic, a pressure wound. It's severe constipation that can wind people up in the hospital. It's dehydration. It's a new medicine that was added, or some refill was filled incorrectly. The pill color changed or the shape changed. Always take a look at that. Or over-the-counter things. Any pain PM is a problem. Not the pain medicine, the PM, because the PM is Benadryl, and Benadryl can cause confusion and hallucinations in older adults, especially those with Parkinson's and Lewy body. Cough and cold medications, if it says plus, severe, max, flu, anything that makes it sound like a superhero, okay? That means that it's got Benadryl or a cousin of Benadryl in it. There are safe medicines out there. We just have to get the ones that are just guaifenesin. That is a safe cold medication. You just have to make sure it doesn't have everyone else tagging along with it. And finally, low blood pressure can be an issue. You saw Sarah at the beginning of the webinar, if you joined at the very beginning, and Sarah has taught me so many things as a social worker. Number one, find a social worker in your community. Thank them because they really do God's work. They do so much. But Sarah has been the person in our clinic to teach us the ins and outs of what do we do as mobility changes in terms of assistive devices and navigating insurance. So here's the thing to know is as mobility changes, there are different assistive devices like walkers available, and they're not all created equal. Medicare will cover one walker every 5 years and one wheelchair every 5 years. They do not say whether they will cover a cheapy walker or they will cover a fancy walker. So we strongly encourage people that if you are just needing something for, a quick moment and it's just to get from one place to the other, but you're not regularly using it, don't spend your Medicare benefit on that. Save it in case you need something fancier and special to help prevent falls with Parkinson's. And you can get a walker first and still get a wheelchair covered by Medicare within the same 5-year time frame, but you can't go backwards. So if you use a Medicare benefit to get a wheelchair, you can't get a walker in that same 5-year period. So it's a little bit of strategy, but for things like a transport wheelchair, a lightweight wheelchair that someone is not spending a great deal of time in, just to get to the doctor's appointment, to the family event, and back, think about lending closets. These are available in communities all across the country. They could be housed in a church, a house of worship, a YMCA, a village hall. For custom heavy duty devices, that's where to use your Medicare benefits. And if someone needs a custom wheelchair, there are seating and wheelchair clinics at most academic facilities that can help customize, trick out the wheelchair to prevent pressure sores, to help if someone is particularly tall or if they've got a wider body habitus so that they're not going to get injured by the chair that should be helping them. In terms of cognitive changes, there are a lot of things that we can do. I talked about some of the day-to-day things, but we're very, very lucky at Rush, and we're very lucky across the country to have amazing neuropsychology colleagues. These are psychologists who do extra training, just like movement disorder specialists. They do extra training in understanding cognitive changes and being able to figure out through different tests what areas of cognition, of memory and thinking are changing and what areas are still strong. Where does a person still have strengths that can help them to compensate? And so a neuropsychological evaluation can help identify areas of change and areas of strength. Also, something to keep in mind is if you or if your loved one is having hallucinations, delusions, or any agitation, you can notify your local police station using their non-emergency line. And if you can't find the non-emergency line, you can call 911 and tell them, I want to speak to the non-emergency line. Let them know that someone at your address has dementia. And if they have hallucinations, if they have delusions, you can tell them that so that if for any reason in an emergency, the police or fire station is called out to your home, they see that flag and hopefully they will approach with care and with compassion. Also, especially if people are having hallucinations or delusions or agitation, please think about if there are firearms in the home, whether that is still safe. Always, always keeping ammunition locked and separate from any firearms, but particularly in folks who have hallucinations with Parkinson's and Lewy body, it may be a time to think about retiring from firearm ownership and getting those out of the house. And finally, sometimes we can see impulsive behavior in people with cognitive changes or wandering, especially outside of the home. So in the home, safety things to think about are kitchen safety, like taking off oven knobs from gas stoves if the person is ever unsupervised. Sometimes people who were great cooks before might forget and they might microwave something with metal. So sometimes we've had care partners and they just, if they're going out of the house, they just unplug the microwave. Placing knives and sharp objects either way high up or way down below can often just be a simple enough solution that gets things out of people's way. And if someone has any history of wandering, different tracking devices like Apple Watches, like medical alert bracelets can be very, very helpful, or setting bed alarms or extra alarms on the door so that if someone tries to leave the house in the middle of the night, someone else in the house is notified. So we're going to talk about some scarier things, but only because I want to share with you things that we can prevent, we hope, and some novel ways to do that. So here are some triggers for hospitalization in people with Parkinson's and Lewy body. The top causes are falls, urinary issues, like I mentioned, dehydration, hallucinations, delusions, agitation, and caregiver strain. So caregiver strain alone is a huge cause. And once hospitalized, people with Parkinson's and Lewy body dementia stay longer. They have excess iatrogenic injuries. What does that mean? Worse things happen to them in the hospital that shouldn't happen because they have Parkinson's. The meds get messed up, not because people aren't trying, but because they just don't get it. They don't understand. They stay in the hospital longer and they're more likely to be discharged not to home, but to a nursing facility. So my team and I had this not rocket science idea, which is that many of these reasons, falls, things like that, many of those things we think could be preventable or manageable at home if we recognize them early. But doing that requires an educated, engaged, and observant caregiver. So who is doing the heavy lifting in Parkinson's and Lewy body? Over 83% of people with these conditions rely on unpaid caregiving from family members. If that is you, thank you. We see you. You are doing amazing work if no one has told you. You are doing 18.5 billion hours of care across the US that if we paid for it, which we don't, we would pay $232 billion the last time it was estimated. We also know that Parkinson's and Lewy body caregivers have higher caregiver strain, burden, high blood pressure, depression, and back pain. Not the people with Parkinson's and Lewy body, the care partners, compared to care partners of people with Alzheimer's. And we know that this is happening because there are so many symptoms and things can change on a moment's notice and they're unpredictable. And like I said, caregiver strain is an independent risk factor for the person with Parkinson's or Lewy body winding up in the hospital or in a nursing home. And so people all the time ask me, ask Sarah in clinic, you can send someone, Jory, right? You can send someone to me in terms of a paid caregiver. And I feel like I am breaking hearts every single week when I have to tell them that our healthcare system is very broken and paid caregiving is not covered by insurance. It's not covered by Medicare. It's not covered by hospice. It is very expensive. Caregivers are in high demand and low supply and often have no training on Parkinson's or dementia or end of life at all. And so for a long time, it felt like the cavalry isn't coming. What are we supposed to tell people? However, I want to share some exciting stuff with you all, which is this idea of peer mentoring for caregivers. So folks may have heard of peer mentoring, which basically means someone who's been through it mentoring someone who's newer on the journey. So people use peer mentoring when college freshmen make it to campus. They pair them up with a junior and say, let me show you where the cafeteria is. Don't take this class, take this one, right? Someone who gets it. It's going to be much better heard from someone who's actually in the thick of it than someone who's, wearing a white coat and doesn't look like they understand, right? And so we tested out this idea of peer mentoring in Parkinson's first, and then in Lewy body dementia. And full disclosure, I was taught the word persevere by my grandmother when I was 4. She raised a child with severe neurologic injury. And I remember her teaching me the word persevere. And if you write a grant, you're supposed to have a catchy acronym. So we made this peer mentor support and caregiver education in Lewy body dementia. And what we did was we held focus groups of care partners and said, what do you wish you knew? If you had a curriculum that wasn't too sciencey and it was practical and it was approachable, what would you want to know about and what would be helpful? And we made that curriculum. We made a program that was entirely virtual, so you didn't have to show up anywhere. And together with partners from the Lewy Body Dementia Association and the Parkinson's Foundation, they shared information all across the US back in 2020, 2021. We trained 36 care partners who were experienced. Their loved one had had symptoms for quite a while, or their loved ones had passed. And we paired up those mentors with people who were newer on the journey. And we gave them this curriculum we created, and we said, you're going to have 16 weeks, talk with each other once a week, let us know how it goes. And we looked to see if that did anything. And lo and behold, despite the fact that people are busy and some of our care partners were grieving the loss of a loved one, they still prioritized this study. They prioritized learning to persevere. They found it helpful. They did over 400 calls over the course of 16 weeks. Everyone said that they would recommend it to everyone else, which is great. And what I think is really encouraging is I told you that it's felt for way too long like the cavalry isn't coming. But we asked people, we know that this is a lot to ask of someone, to get on the phone with someone that they've never met and hear about their problems and share your story. 90% of our mentors said, I would absolutely do this again. And when we asked the mentees, 40% said, I'd like to do another round as a mentee and go through this again. 10% were like, I'm good, leave me alone for right now, I'm good. But 50% said, I'm ready to be a mentor now. I'm ready to pay this forward and help someone else coming up behind me. And in addition to that, we saw improvements in knowledge about Lewy body. We saw improvements in attitudes towards caring for people with dementia. We even saw a little bit of a trend towards care partners' depression improving. So what that led to is a study that we have open now. And so that QR code, if you're seeing that, if you are interested, we have an NIH-funded national randomized control trial that is entirely virtual. If you are in a US state or territory right now and watching this, you may be eligible. It is for family care partners only. So if you're a person with Parkinson's or Lewy body, we see you, we appreciate you, but this study is not for you. This study is for your care partners. And it includes weekly disease-specific practical guidance over a 12-week curriculum, and then about 6 months of follow-up. And the follow-up is just we check in every 2 weeks with a quick survey. And we are still recruiting for experienced care partners who we will train as peer mentors. And then our caregivers are folks whose loved ones are having cognitive changes, but are within the first couple of years of those cognitive changes happening. And that's the group that will be randomly assigned to either get the full deal or sort of the lighter intervention. But I want to be really clear that everyone in this study gets 12 weeks of education and resources. We were not okay with the traditional control group and telling folks, sorry, you've been randomized, you get nothing. That does not happen here. So with that, please, if you are part of a support group, if you're part of a network, if you think that there are other folks in your community, in your house of worship, who may have shakes, who may have tremor, this may resonate for, please feel free to share this with them. Please feel free to reach out to our team. We've got all the flyers in the world. We're happy to show up and talk to any support group that will have us, but that information is there. We are also, because we have care partners who are part of our study and tell us what we should be doing, they said, Jory, people are learning information on TikTok and Instagram. And so we said, well, we had some comments first. And then we said, okay, I guess we should do that too. And so if you're on TikTok or Instagram or Facebook, you can follow us there. Right now, we're just putting out helpful daily tips and tricks and things like that. But this is not the only opportunity. So at Rush, if you are in the area of Rush in Chicago, we are the primary site for a study specifically looking at racial disparities in Parkinson's disease. And so individuals who are English speaking, who have a diagnosis of Parkinson's and identify as Black or white as the control group can participate. If you are interested, again, happy to share out these slides and we'll share the recording, but the contact info is here. And if you are someone who's been diagnosed with Lewy body dementia or dementia with Lewy bodies, we also are part of a huge national consortium for that. And so this is a huge study that's going on and follows people annually with dementia with Lewy bodies. What else? I want to wrap up really quickly, but share these last few things with you is you should never be alone. When searching for this diagnosis, when coping with this diagnosis, this takes a team, and the person with Parkinson's, the person with Lewy body should always be the quarterback, the center of that team. Choose your sports analogy. Surrounding them are their care partners, their family, their friends, their chosen family. And then the primary care doc, their neurologist, your social worker, your physical occupational speech therapist. There are so many in the community who have so much to offer, and it takes time to build that team. That includes dietitians, psychologists, psychiatrists, but also spiritual support. Faith communities are invaluable. So please build your team, strengthen your team, thank your team for being there for you. For family, friends, and neighbors, oftentimes we hear from our care partners, yeah, people have offered help, but I don't even know what to ask them. There's so many things on my list. I don't even know what to do. Make a list. Just make a list. If there's something that you can think of, laundry, housekeeping, yard work, calling the plumber, the cable company, the someone, keep a running list somewhere. And when someone says, let me know if I can help, you pull up your list. And it just might be, do you have a friendly teenager who can come and mow the lawn? That would be awesome. That takes something off of my plate, right? grocery orders, picking up, unloading, meal prep, setting up meal trains, asking someone to just, if you could come over on Thursdays at 5 so I could go whatever, maybe just walk around the block, maybe go in another room and scream into a pillow, right? But something where you know as a care partner, you have time to yourself and the person with Parkinson's or Lewy body has time with someone. That's often a really, really amazing gift for people to give. Transportation to and from appointments is huge. And then faith communities can be huge sources of support. As I mentioned, many churches will have contingents of folks who are willing to be friendly visitors and just drop in on someone. Sometimes they might be willing to transport someone to and from church or synagogue. They might provide companionship and come visit the person and watch services online. Any of these things can be tremendously helpful. Just remembering that asking for help is a sign of strength is really hard for most people. I want to point out that in addition to the many, many support groups that we have at Rush, we actually have a support group specifically for Black patients and families with Parkinson's disease. If folks are interested, please reach out. Let us know. Everyone is welcome. And then there are so many resources available. So I put this goofy cartoon that says, it's okay, Stan, just pick one flower and start from there. We are so lucky that there are so many different foundations and organizations in the Parkinson's and Lewy body world that continue to produce really high quality, trustworthy content. So there are support groups all over the United States in person and virtually. There are foundations that offer hotlines and helplines. So the Lewy Body Dementia Association is terrific. I'll point your attention to the Davis Phinney Foundation. This is more Parkinson's focused. We had the opportunity to develop an entire free care partner training program that is technically Parkinson's focused, but applies to Lewy body as well. That is free. You just register. They also have a lot of Spanish language content too. Huge shout out to the Parkinson's Foundation. They have invested a tremendous amount of time and energy and amazing personnel over the last decade in building out content specifically for communities of color. So they have a whole website that has all kinds of resources here. There's a book called Parkinson's Disease in the Black Community, How to Live Better, and that's in collaboration with blackdoctor.org. They have a video series talking through myths associated with Parkinson's and the role of faith and spirituality in navigating Parkinson's. They do a far better job than I do, and I won't even try. So I want to point you in that direction. And here are just a couple of those resources as examples. Dr. Hiral Shah and an amazing group of people and care partners with Parkinson's put together this book called The PD Movers, We Keep Moving. It is a beautiful storybook with people's actual real life stories of living with Parkinson's, and that's available to folks at this website, apdaparkinson.org/PDmovers. And if you need more, we put together at Rush, we have this Rush Parkinson's and Movement Disorders Patient Education page. If you just Google Rush Movement Disorders Patient Education, you'll get there. There is a Google map that you can search for support groups, exercise things, all kinds of stuff in your area. You can zoom in. If you know about something and it's not on the list, there's even a form where you can send it to us so we can add it. As I mentioned, we have our support group for Black patients with Parkinson's disease. And on that website, if you scroll down below the Google map, you will see all kinds of videos about all kinds of different topics in Parkinson's, Lewy body, and more. If you are interested in signing up for any support groups, we've got a QR code. You can let us know what you're interested in. And here are some more. So I hope you are walking away overwhelmed with resources because for too long, there's been too little. And finally, we have many, many foundations and many researchers and many clinicians and the community involved together to try to serve people with PD and LBD. So in conclusion, I hope you've taken from this that Parkinson's is bradykinesia, slowness of movement, at least one of rigidity, tremor, postural instability. And although we call it a movement disorder, there are many, many non-movement symptoms. It is not just normal aging. It is under-recognized, underdiagnosed, and understudied in people of color. Lewy body dementia, or LBD, is the second most common cause of dementia. It is that Parkinsonism chicken plus the dementia egg, and it is also often misdiagnosed or undiagnosed. And people have changes in their attention, their executive function, their decision making. They have those hallucinations, those fluctuations. And we can manage and make a difference in most symptoms and in people's quality of life. Our motor management for movement symptoms, levodopa is both our safest and our most effective treatment. It doesn't stop working. We just need to adjust as time goes on. We have medication and non-medication options to help with memory and thinking, hallucinations, delusions, constipation, the blood pressure changes, all of this. They all have a big impact on life, and we can do something about them. So no one should be suffering with that untouched. We also know that our care partners are really holding the world on their shoulders. They have higher strain than our Alzheimer's care partners. That independently increases the risk of their loved one winding up where they don't want to be, but there are things that we can do. There are so many resources available for all people and families with Parkinson's and Lewy body, including specific supports and research studies focusing on communities of color. And finally, just a last plug for the Persevere study. We are enrolling across all US states and territories. If you are a care partner and you want to support another care partner, if you're a care partner and you want support from another care partner, hit us up, check out the QR code. We would be thrilled to have you. So with that, I want to acknowledge my kids who tolerate me being away at night to give talks and always encourage me to figure out what can we do to make tomorrow better and look to the horizon. My grandparents, who, as I mentioned, taught me the word persevere when I was younger and then taught me that word again because when I went into movement disorders, we did not have movement disorders in my family, but both of them developed Parkinson's and Lewy body dementia respectively. So I have seen what caregiving looks like on a 24/7 basis. And I didn't think I could have more respect for our care partners, but oh, do I. So with that, I want to thank you all so much. I'm sorry for taking so much time, but I'm happy to stick around and answer questions. I will stop sharing my screen. And let's see. I will stop sharing my screen, I think.
You did. We can
Okay.
see the audience. We have some great questions in the chat that people have been sharing during your talk that you can reference and maybe start there.
Tom, I hope we covered enough Lewy body dementia for you. I see that at the beginning. The patients in the video on Parkinson's medication, some of the patients were on Parkinson's medication in those videos, some were not. Some of the videos that didn't play, they were on and off medications, and that would have been awesome to see, but you know, sometimes tech happens. Deb wrote, we just learned that any person who served in Vietnam 1962 to 1975 and were exposed to Agent Orange will probably get Parkinson's. I think the numbers are still kind of the probability varies depending on the study that you read, but absolutely it is a much higher risk than someone who was not exposed. And if you are a veteran, please look into service connection. If you're getting care at a VA, if not, please look into getting care at a VA because you may be able to get service connected if you have Agent Orange exposure. Do Parkinson's meds lower or raise blood pressure? Says Elaine. Elaine, that's a great question. Levodopa can sometimes lower blood pressure. Some of the others can lower or increase depending. So that's one of those things that we often have to balance out. It doesn't necessarily mean it's a reason not to use levodopa, but to use it sort of even more cautiously. Donna wrote regular, not PM Motrin really can be an issue too for my guy. You know, I have to say, Donna, I hear this from many people, including people in my own family. I cannot biologically explain to you why ibuprofen or Motrin or sort of those NSAIDs should cause sleepiness or confusion, but I've heard it enough times, especially in folks with Parkinson's, that it certainly is something that could be happening. Karen asked, what do we say to our doctor if the patient suddenly starts acting different and you figure he has a UTI since he probably doesn't have other symptoms to describe? Oh, Karen, such a good question, because here's what's happening. I love watching Sarah smile because she knows the spiel, okay? If you go to the emergency room, our emergency care physicians are trained to say, well, if there's bacteria in the urine, but the person is not complaining of urinary symptoms, that is asymptomatic bacteria in the urine and not a urinary tract infection, and we don't need to treat it. And you can be the squeaky wheel. You can pull up references from Parkinson's foundations, you can just tell them that your Parkinson's doc or some random blonde Parkinson's doctor on TV, right, told you that your person cannot complain of urinary symptoms because their Parkinson's symptoms are suddenly so much worse. If they are hallucinating and they think the SWAT team is coming in through the curtain, they are not going to recognize whether their urine is a slightly different color of yellow. Okay, they're not going to say, oh, it burns a little bit when I pee, or I think I went 7 times today instead of my usual 5. No, they are going to be shuffling or freezing or falling. That is their symptom. So that is what you tell the emergency room doc. That is what you tell your primary care physician. I have very strong feelings about this. Thank you for allowing me to step on that soapbox. Donna also asked, how readily available is the skin test? So I think Donna is referring to an alpha-synuclein skin biopsy, which is something that is increasingly common and increasingly studied. Depends on where you are, how readily available it is, and whether your healthcare system has figured out how to get it through insurance or not. It is not 100% super easy yet. What this is researchers have found that that same alpha-synuclein that goes wrong in the brain can actually be seen glommed up in the skin. And so a skin biopsy involves taking a teeny, smaller than the tip of sort of the end of this pen, if that will show, maybe not, smaller than a pencil eraser, from just behind the neck, sort of on the trapezius, the meaty part of the shoulder, just above the knee and just above the ankle. The challenge is that people with Parkinson's, Lewy body can have abnormal alpha-synuclein. People also with multiple system atrophy, which is a related condition, can also have abnormal alpha-synuclein that we see in the skin. So there are research studies showing that it can be very sensitive and specific and kind of help us figure out which category is a person in. But right now, the way that the lab runs those studies, and this all goes to one particular lab, just comes back as basically alpha-synuclein, like misfolded alpha-synuclein, yay or nay. So it's not quite as Parkinson's versus Lewy body. It can't really tell us that yet, but people are working on this. Elena asks a great question. How does caregiver strain contribute to hospitalization frequency? I'm so glad you asked this. And we are trying to study this because shockingly, there's no one clear answer. But several of the things that we think contribute is we know that as Parkinson's goes on, as Lewy body goes on, people's sleep is really disturbed. And if the person with Parkinson's or Lewy body isn't sleeping, the care partner often is not sleeping. And if you've ever done a few all-nighters in a row, if you think back, if you've had kids, think back to that newborn period where you were waking up all of the time, you were probably not thinking straight. And there was probably some time where you responded to something and thought, oh man, if I'd been like fully alert and conscious, I probably would have done something different. So we think that some of the time there may be, subtle symptoms that are going on that really exhausted care partner might just not be picking up on, right? It can be really hard to pick up on that first change that should tip us off to a urinary tract infection, or sort of like the, almost falls, the near misses. And things kind of progress to the point where the person is frustrated, they're upset, the loved one might be having hallucinations and they're arguing with them. And so things can really escalate. And we think that those are some of the contributors of how caregiver strain is leading to those excess hospitalizations. Oh, Elena asks, what is the Instagram handle for Persevere? I will put that in here for everybody. So the Instagram and the TikTok are both at the Persevere Study, the.persevere.study.
And then maybe
sorry.
while you put that in, Karen also had a question about, she has a loved one with young onset diagnosis and is wondering if there's anything that can help slow the progression of Parkinson's.
Yes, exercise. Period. Full stop. And that's the same whether someone has young onset, whether someone has later onset. The one thing that we know, and there is no one right exercise. So you do not need to spend gajillions of dollars on a fancy bike. You can go get beat up tennis shoes as long as they are supportive and your loved one is not falling. you can go for a walk.
Love.
Anything that gets the
I
heart
want to
rate
buy a
up,
gay hippie. Yes, but they're gonna keep.
anything that gets the heart rate up, anything that gets a person sweating. And if that feels too much of a reach right now because your loved one is doing very little movement, that's fine. Start with something. Start with moving around in the chair. There are, if you go to Parkinson's Foundation, they've got Parkinson's Health at Home, I believe is the title. Sarah's nodding her head. Parkinson's Health at Home. During the pandemic, everyone and their mom started and said, I know people are at home, they can't do their usual classes. I'm going to create content online. There's so much Parkinson's exercise content online. If you're a dancer, amazing. Dance is great for Parkinson's. If you're a swimmer, fantastic. Go get in a pool. If you like to bike, wonderful. If you like to walk or run, fantastic. The thing that will work is the thing that you will enjoy. Ideally, something that you do with someone else. It gives you social interaction. It gives you accountability. It gives you camaraderie. Those are huge motivators that will keep you doing it. If there's something that you can share with a kid, with a family member, with a grandkid, we had an amazing program, it's still going on, of karate for Parkinson's. And we have people with Parkinson's who've been doing karate for years, and now they're teaching their grandkids. They're teaching their kids, and they're in those classes together with them. That is amazing, right? Something where you can not only see what Parkinson's is changing or taking away, but you can see yourself improving and making gains. That is how you fight back, and that is how you slow this down. Donna asked, would a personal fan help someone who's having autonomic issues with being too hot and sweating? Yes. So we didn't really talk about it, but thermoregulation, control of body temperature, can be a huge part of Parkinson's and Lewy body. People can be super hot and sweaty one moment, and they strip down and they take off all their layers, and then the next moment they're freezing cold. And it can feel like that thermostat is like hanging out of the wall by a wire, right? And so breathable layers, cotton, bamboo, linen, kind of natural fibers will help breathe. But also fans can be really great. Instead of a giant ceiling fan that's on, Apache helicopter setting, having a more personal fan that's directed at the person so that the bed partner isn't blown out of the bed can be really helpful. Cooling towels can be really helpful. All of these kind of things. Sarah, what did I miss?
Someone put in the chat, is exercise equally as good for someone living with Lewy body dementia?
That is a really good question. There has been less research on it. So from a scientific perspective, I cannot tell you that there is as much data, but we have every reason to believe yes. There are very similar brain changes going on. They're just kind of happening in a slightly different pattern. But there are so many things that we know exercise does on a microscopic level in the brain. It helps prevent free radicals. So basically, your brain is kind of a fuel combustion engine, and there's kind of, toxic stuff being emitted, and exercise helps you clear out those exhaust fumes better, right? It's like switching from a fuel to a hybrid or to an electric vehicle. So that is one great reason. It helps the dopamine producing neurons that are still there stick around for longer. It helps brain cells connect with their neighboring brain cells better. There's all kinds of ways that it helps. So it stands to reason, and we certainly have no proof to the contrary, that exercise is very, very helpful in people with Lewy body. And I would say even more so the social piece and having a regular schedule. Lewy body especially tries to change people's schedules. It has them sleep during the day and be awake all night. We don't want that. Find that class that the person can go to, not super early in the morning, but something where they're going to get up because Bob's going to be waiting for them. Mike's going to be waiting for them. We don't want to disappoint, even if you don't feel like doing boxing, right? Someone is waiting for you. That's often a great motivator, and it keeps that person on a schedule.
Another question in the chat is around the VA, considering Parkinsonism and Parkinson's disease as presumptive conditions for Vietnam veterans. And so the people are wondering, do you know if Lewy body is also included on that list of presumptive conditions?
I believe it is, but I'm not 100% certain. Sarah, do you know? I'm gonna turn this back to Sarah because
I
she's
know.
often our VA expert, even though she does not work at a VA.
I also think that it is, but in this moment, I can't tell you with 100% certainty, but I do believe we've had other vets with LBD who have been able to get benefits for their service in Vietnam.
Are you going to get to all the questions?
We're trying.
Did we miss one? Did we miss your question?
I had two.
Okay.
The first is I live in Oregon. And I think the law in many states is similar that guardians for protected people need to consult with them about decisions they make. And how is that affected by the fluctuating cognition that's associated with LBD? So how does a guardian know when's a peak time to talk to the protected person to have a meaningful consultation?
A great question. Sarah, do you want to take that? I'm happy to take it, but
Must have been a good question.
no, it's a really great question. So full disclosure is Sarah and I are lucky enough to work in our AIMS clinic, which is an advanced interdisciplinary movement disorders supportive care clinic, where we have a lot of conversations about goals of care, planning for the future, talking with guardians and things like that. So she is quite the expert in a lot of these conversations and topics. So I want to let her shine too.
I would say if there's certain times of day, if your loved one or the person that you're a guardian for has certain times of day that they tend to do better, that would most likely be a good time to try or to start. But we've had people who are going to the attorney to sign updated legal documents, and they were really clear and sharp when they had the appointment with the attorney to articulate what their new preferences are and the changes they'd like to have made. And the attorney says, okay, come back in 2 weeks. We'll sign all these documents and I'll notarize them. And they come back and they're in a fluctuation and they're more confused. And the attorney says, we can't do this today. We'll need to make another appointment. So I think there is also a recognition that you might have to make a couple attempts, and which can be frustrating. And as you're articulating, really difficult to plan because we made an appointment, we got on the attorney's schedule, Tuesday at 10, and Tuesday at 10 on this particular Tuesday was not a good day. So we may have to make another appointment and come back and try again. But we've had attorneys that have been very willing to have a couple appointments with people because they know or are more aware that I had a very coherent conversation with this individual. And so I'm willing to give it a couple tries to see if we can catch them in a good spot and we can finish these documents.
Okay, and the other question I had was, what's the recommendation for the long-term use of a drug like Seroquel with someone with LBD and Parkinson's, and also how it might affect their ability to participate in decision-making, as well as get them calmed down or whatever reason they're giving it to them. So it seemed like it's a complex thing when we start to use antipsychotics.
It is quite complex. So I just want to say as a one point to what Sarah was saying, one of the other things that we found helpful when having conversations, especially if someone fluctuates, is knowing that there are some resources that can help so that if you have that moment at home where it's possible, in sort of a non-fluctuation moment, there are some great websites out there that can help sort of guide the conversation. So conversationproject.org and fivewishes.org are both really, really helpful. And conversationproject.org is from Dr. Atul Gawande's research team. So if people have read Complications or the Checklist Manifesto, this is from that same kind of research team. It's terrific. And they have a conversation guide specifically for people with dementia. It's not Lewy body specific, but when you have one of those good moments, it's something to start talking through. As far as Seroquel or quetiapine, so this is an antipsychotic medication, and Uncle Google, which has lots of thoughts about Parkinson's and Lewy body, Uncle Google went to a cruddy med school in the Caribbean and did not graduate. So please take all of that with a grain of salt. there are a lot of things out there about antipsychotics. And while it is absolutely true that there are many antipsychotics, nearly all of them, depending on the dose, carry a risk of worsening the movement symptoms that someone has, especially in someone with dementia with Lewy bodies. There are better and worse choices. And I've had, we've certainly seen people in clinic where the person, or more often the family and care partners, are so afraid, based on what they've read online, of using any antipsychotic medication, that our options are essentially to reduce all the rest of their meds, wean them off of levodopa, because while levodopa is helping with movement, it could be fueling some of the psychotic behavior as well. But then that means that that person is often rendered totally immobile. So that's really not a great choice if we don't have to do that. Or they may not be able to remain at home. So while we don't willy-nilly throw around antipsychotics, we do use them judiciously in people who are having bothersome or dangerous hallucinations or delusions. So if someone is just kind of picking at lint, or some schmutz on their pants, not something that we're going to medicate. But if someone is constantly seeing little mice running across the floor and they're reaching and they're falling out of their chair, that's someone who we would think about something. And different antipsychotics are better than others. So quetiapine, which you mentioned, is kind of the most common one that we reach for, and we use it in the movement disorders world. We use doses that our psychiatry colleagues laugh at. So we use the equivalent of a dose that's like taking a pill and wafting it by someone's nose. So psychiatry, they use doses like 150 milligrams, 300 milligrams of quetiapine. We use 12.5. But for someone with Parkinson's or Lewy body, that is often enough. And it's at least a place to start and gradually work our way up. The things that we need to be concerned about are certainly all of those medications, as their main side effect can cause sleepiness or sedation, which is why, like anything else in Parkinson's or Lewy body, we should be starting at a very low dose and going very slowly as we're increasing, to try to find, with everything, the lowest dose that controls symptoms and balances quality of life. And that is different for everyone. So usually for most people, and I say this as someone where Sarah and I spend most of our time in that kind of realm of Parkinson's and Lewy body, we can find some balance between controlling motor symptoms and controlling the psychiatric symptoms, so that the person is not just, well, they're not hallucinating anymore because they're asleep, right? That is not the goal. I hope that answered your question.
There's
Yeah, that was
another.
pretty good. You mentioned two groups of 5wishes.org and another one, and I didn't get to write that down.
Conversation Project.
Conversation Project. Okay.
.org. Yep.
There's another question about medicine in the chat around rivastigmine and how
to get
to
it covered.
get it covered for someone with Lewy body dementia.
This is tricky. This is also let me get up on my soapbox. Sarah is smiling. So rivastigmine is in the group of medications called acetylcholinesterase inhibitors. That is a mouthful. These are the ones that we believe slow down the progression of disease. However, rivastigmine comes in a patch form, which tends to have fewer side effects than rivastigmine in pill form, or its older cousin that's been around for longer and is cheaper, called donepezil or Aricept. Donepezil and Aricept can both work really well in people with Parkinson's and Lewy body, and are often what we have to start with from an insurance perspective, because many insurances will refuse to cover rivastigmine or the Exelon patch if I write for it as the first thing. They will say, no, the person needs to try and fail other options first, which means we try donepezil. And I tell people very clearly every day, we are going to start donepezil. It may work beautifully. It may have an added benefit that it sometimes loosens stools, which, if you are someone with severe constipation, may be an added bonus. However, if it causes diarrhea, I want you to not call me. I want you to use that annoying electronic health portal, and I want you to send me a message. And I want it to be as descriptive as possible, telling me what happened. because I will then use that description of what happened and I will copy and paste it into the letter that I send to insurance and say, well, my friends, we've tried and we've failed. And here are the details. You wanted them. Now, may I get the patch for my patient? That's what we do. Hold on 1 second. I have a visitor.
I will continue to try to get through as many questions as we can. Thank you for all of the thoughtful questions in the chat and the continued staying after the time that we initially set. So we're so grateful. This will be shared, the recording and the slides will be shared with everyone. But another question from the chat, Dr. Fleischer, is it possible to have a negative Parkinson test result, but then later be diagnosed with Lewy body dementia?
Yes, it is. So it's hard to know exactly what the person means by negative Parkinson's test result, but no test is 100%. So that's number one. I know several times I see people talking about the skin biopsies. The skin biopsies are not 100%. Even testing, which is coming soon, is to be able to look for that misfolded alpha-synuclein protein in the spinal fluid, is not 100%. It's closer, but it's not 100%. So this is really, really difficult and frustrating in medicine as we think that we're going to go into medicine. It's like, aha, okay, person presents with these symptoms, you test for this, it comes back positive, they have this. And that is not how things work. Life would be much easier if they were. So no tests are 100%. I wonder whether the person is referring to a DAT scan, which is a kind of imaging test that looks, it's not like an MRI, it's not very detailed. It's basically a drive-by image, like a cruddy Polaroid, that looks at those dopamine producing cells and looks at the ends. If you remember that ugly scientific picture that I showed you with one cell coming down from the top and all the different kinds of medications, it basically is giving you a tracer to stick to the dopamine spitting out neurons. And if you've lost some of them, then the image is less bright. And so that can be abnormal in people with both Parkinson's and dementia with Lewy bodies, but it can also be normal in people who later go on to have more symptoms. So that test, none of these tests are 100%. So I think the takeaway from that is if you are having symptoms and someone tells you, nope, based on this one test, you don't have it, trust your body. You can always seek a second opinion, especially if someone is like, oh, absolutely not. You might really want to seek a second opinion. So someone wrote, their father is clinically manic, has been for months following a heart ablation, like some idea of whether mania is associated with LBD, which is a suggested diagnosis, though unconfirmed. And I saw a question about getting a Watchman heart device inserted. So I want to touch on, I think it's hard to give specific advice around those specific situations, but I think it does broaden out to a question of people who maybe did not have symptoms until a procedure, general anesthesia, and then things seem to sort of start, which is increasingly recognized as that can be a presentation, especially for Lewy body dementia, is the person was fine, and then all of a sudden, after anesthesia, after the hernia repair, after whatever it is, they were never quite the same. And we don't fully understand why, but what we think is going on is, as I told you, by the time someone has symptoms, they've already lost 50 to 60% of those specific brain cells. So that surgery, that anesthesia did not cause the Parkinson's or the Lewy body, but that person's brain was kind of slowly percolating towards that. And this may have unmasked or kind of accelerated the presentation. So maybe they would have developed symptoms a year later or 2 years later, but for whatever reason, the general anesthesia or complications during surgery or just the prolonged recovery seems like the brain takes a hit and whatever compensation was going on is suddenly stripped away in a really big way and we kind of see underneath. So I usually tell folks for any procedure, if we can minimize time under anesthesia, great. We obviously don't want people having procedures awake, but for their, clinicians, their surgeons to take that into consideration and to recognize that in someone who has a diagnosis of Parkinson's or Lewy body and they're getting some kind of procedure, the next couple of days may look a bit different. Doesn't mean that that's their new baseline necessarily, but go in with the expectation that movement may be worse, cognition may be worse, hallucinations, delirium in the hospital with confusion, more hallucinations is very, very common. That's when you want to bring something like, look for Parkinson's Foundation has something called the Hospital Safety Guide, or LBDA has hospital safety tips and medical cards that people can bring. You shouldn't have to educate your healthcare providers, but often you have to educate your healthcare providers. You may be far more knowledgeable about Parkinson's and Lewy body than they are. And it is not for lack of trying on their part. They're very, very knowledgeable about whatever they do, but it's not this. So be the squeaky wheel, be the squeaky care partner, be the annoying family member. I certainly am. Wear it with pride, but that is keeping yourself, that is keeping your loved one safe and healthy. Other questions? You guys have so many great questions. Thank you all for being here. Thank you for sticking around for a super, super long webinar. Did not intend to go so late, but thank you all for sticking around for it. Thank you, Sarah, who has dinner and small people to get to. And thank you all, whether you are living with Parkinson's or Lewy body, thank you. We see you, whether you are a care partner. I see some unbelievable, long-standing, amazing care partners out there who I know. I see you. Thank you for being here. We just appreciate you so much. And a huge thank you to Sarah, and a huge thank you to the Alive Faith Network, the Thrive Alive podcast team, for this collaboration. So have a
good
wonderful
night,
night,
everyone.
guys.